Thank you for hitting play on Children's Pedcast. I'm Jimmy Bellamy, and this week I sit down with Dr. Anupam Kharbanda to talk about appendicitis. Dr. Kharbanda's specialty is pediatric emergency medicine at children's hospitals and clinics of Minnesota, and appendicitis is an area in which he has done a considerable amount of research. He's here to answer the questions parents have about the signs and symptoms to look for, how appendicitis is diagnosed, when an appendectomy should take place or does take place, what other ways there are to treat appendicitis, what recovery time looks like. There's a lot of questions because appendicitis is fairly common. We see a lot of cases each year with children coming into our hospitals who are diagnosed with appendicitis, and he's here to help with anything that you may suspect when dealing with a potential case of appendicitis in your child. He'll also break down the differences between appendicitis in children and adults and provides a lot of information regarding research in the area. You can find us on Twitter at Children'sMN. You can find our website at childrensmn.org. And you can find our podcast on iTunes, Vimeo, YouTube, Podbean, Stitcher. And on iTunes, if you do us a favor and rate and review the show, that helps the algorithm to bump us up a bit and help us get seen. And you also, through iTunes, can subscribe to the show. So each episode, when it's published, will automatically download to your device. Enjoy this episode with Dr. Anupam Kharbanda. You've done a considerable amount of research when it comes to appendicitis. I want to talk about that, but first, for a parent or anybody who hasn't had to deal with it either as a child or now as an adult, your kid experiences appendicitis. First, what is an appendix? What does it do? How does it work in the body?
So the appendix is a structure that is about 3 to 4 inches in length. It comes off the cecum, which is part of the intestines. And as clinicians, we don't really know what its purpose is. We believe it's a remnant sort of structure that exists within the body without a whole lot of function. That being said, it does contain what we call lymphoid tissue. And these lymphoid tissue can expand or contract with viruses. And that's will come to be important as we talk about how do children get appendicitis. But in general, the appendix is the structure that lives off the cecum, and it contains the same amount of gut flora and bacteria that the rest of your gut contains.
When appendicitis is being experienced, is it the first sign of pain that you realize that this is happening, or is there something that's happening before a child experiences pain?
So what appendicitis actually is an infection of the appendix. And how that happens, or how we believe it happens, this is all sort of theoretical, is that there needs to be an obstruction of this tube, or the lumen. And that obstruction is thought to occur in 2 ways. The first is through a small stone that we call a fecalith, and that blocks the exit of the tube. So you can imagine a blind-ending road that now contains bacteria and gut flora that starts to multiply, and they can't move out. They're not free-flowing. So they start to multiply. They are allowed to get a hold of the surrounding tissue. Once they get a hold of the surrounding tissue, you start to get a localized infection. That localized infection is perceived by the patient as pain around their belly button. As the infection progresses, you get more and more of an immune response to that area, and then the abdominal pain is perceived on the right side. So the first signs usually to a patient are pain around the belly button. As the infection progresses, you start to see very focal right-sided pain as the body starts to contain the infection that's going on in this tube. So I described one way that this blind-ending tube can be blocked. That's with a fecalith. The second is what we think is due to the lymphoid hyperplasia. And the reason why we think this occurs is that we see a spike of appendicitis during the periods of time from April through June. And that's when we see more stomach viruses as well. So these viruses tend to cause these lymphoid tissue to become bigger. And they can actually act as a stone to block the path of the exit from the tube. So whatever gut flora are in that area will multiply, will take advantage of this intercurrent virus to make a little home for themselves and cause a localized infection.
Is the appendix located in the same spot for everybody? And when I say that, I mean, sometimes you hear cases where someone was born and their organ A, B, and C were in a different place. Is the appendix always located in the same spot? And if so, where is it?
It's a very important question. We believe that the appendix lies in roughly the same location in the majority of people. So just off the cecum, at the junction between the small and large intestine. It can have an interesting lie, though, within the abdomen. So that's where we look for it anatomically or radiographically. But where that appendix lies, because it's up to 4 inches long, can be down low in the abdomen, or it can lie high up closer to the surface. And that can impact a perception of pain for the patient, meaning do they feel pain really low down in their abdomen or somewhat higher, or do they have more pain with walking? So that difference in where the appendix actually lies will change a patient's perception, and that's why, as physicians, how we have to be cognizant of its of different types of pain, and could it be appendicitis or something else?
I want to hear about your research, and I'm wondering one area about it. Is it possible to predict that someone may have problems with his or her appendix based on how it looks prior to there being any kind of problem?
There is a body of literature that looks at the genetics, and if your parent had appendicitis or your grandparent, would that put your child at higher risk? And to date, I'm not aware of any literature that would say that we've figured out what gene that might be out there. That being said, as a physician, I have certainly seen many families who said, well, when I was a child, or when Johnny's dad was a child, they had appendicitis. And there seems to be a correlation of that there is something that sets someone up to have this versus someone else. So I think clearly there is a genetic component. Now, on top of that, the thing to think about or to know is that appendicitis is very common. This is the most common surgery, emergent surgery that surgeons do. It's something that we see at our hospital numerous times a year, and it's something that I evaluate for patients on numerous times a day. So belly pain is an extraordinarily common complaint for families to bring their children in, and their concern oftentimes is appendicitis because of their own experience. They know someone who's had it, and so for that reason they're concerned.
Can a strike or a blow to that area cause a burst? And if so, is that considered appendicitis if it's brought on by force?
It is not. So if you undergo a trauma and that causes an injury to a part of the intestines, that would be a different presentation, usually because of either bruising and blood coming out into the peritoneum. Appendicitis is a localized infection. That infection starts as a primary point because that bacteria is allowed to multiply. And so once it starts to multiply, and it takes a hold. Now, from the same line of thinking, we can understand if a piece of fecalith was blocking the exit of the appendix, if that stone suddenly would be removed, the patient would start to get better. And sometimes when you talk to families, they'll give you a history. Well, my child has had repetitive bouts of abdominal pain over the course of a year or months. And it may have been that they were having what we call chronic appendicitis, where there was some intermittent blockage of the appendix lumen, and eventually they had a more severe episode.
What are some of the other signs and symptoms of appendicitis that kids experience?
So for children, we tend to think of a constellation of signs or symptoms that we would say are prototypical. Not all children have it, and it does vary by age. But for a child who's between the ages of 8 and 12, which is the classic age for appendicitis, this is how they often would present. They'll start with that vague abdominal pain around their belly button, and then over 24 hours, that pain moves to their right lower quadrant. as the infection becomes more localized. Along with that, they usually start having pain with walking. They may walk with a bit of a shuffling gait. They won't want to run. As physicians, we often will ask the child in our examination room if they have pain when they hop or if they run. And that's something that parents could also look at home. If your child is having pain with walking or pain with running, that's a sign that something else is going on. So it starts with this pain around the belly button. It moves to the right lower quadrant. The child starts to feel nauseous. They may start to vomit. And usually they also get a little bit of a low-grade fever. That constellation occurs over roughly 24 to 48 hours. After 48 hours, what we start to see is that appendix could burst. And the reason, again, is that the pressure within that lumen starts to build as that bacteria continue to multiply. And as they multiply, they're getting bigger and bigger, and they're making more pressure within that closed lumen. And eventually, as the body starts to fight it, it breaks down the appendiceal lumen. The example that many people give is of a rotting banana. And that rotting appendix will eventually burst, spilling contents into the rest of the abdomen. So you start with a focal pain that becomes more diffuse after 48 hours. So after 48 hours, these children can be much more ill-appearing and with much more sort of systemic signs or symptoms.
And if that spreads throughout the body, what kind of risks are we talking about here?
So as physicians, we really want to prevent that. What we call appendiceal perforation is what we're trying to prevent in our entire assessment and management, and we sort of realize that we have about a 48-hour window. And, it's give or take, let's say, 24 hours, but roughly we have about 48 hours from the onset of symptoms to try to make the right diagnosis. Once the appendix bursts, these kids still can do well, but they tend to have a more prolonged course because now the infection is in the abdomen and not localized as it was like an abscess. And so they'll often require IV antibiotics. They'll require longer hospital stays. And usually once the appendix is burst, the surgeons will take a more of a approach of antibiotics for a period of time, and then an appendectomy 6 months later after the child's has recovered.
Okay. When it comes to adults and kids and the differences with appendicitis, one I think of is a child may not be able to tell the parent exactly what he or she is experiencing, but what are some of the other differences? And then related to that, is it possible for a child to be too young to even convey because he or she doesn't talk yet? Can a child at an early age experience appendicitis, or what is the earliest age?
Right. So these are both very important questions that come up. The difference between adults and kids. Adults can get appendicitis just as a child can. The biggest difference we see as physicians is the differential diagnosis. In children, appendicitis or I'll start with the differential. For a child, your differential would be a viral infection like gastroenteritis, constipation, a viral infection of some type, appendicitis. We think of ovarian processes in female. We think of testicular problems in males. We also think of gallbladder disease. So those are roughly the differential that we come across. In adults, you have a similar differential, but cancers also become higher on our list. Gallbladder disease actually is much higher, and things like a Meckel's diverticulum or some other infection of the intestines are raised in our differential. So the adult physicians tend to have a somewhat different view of appendicitis, and they tend to want to use imaging more because their differential is somewhat expanded. In pediatrics, so in children, we tend to have what I would say is a more narrow differential, and the dangerous outcomes, being appendicitis, are on one end, and the non-dangerous ones tend to predominate, meaning most children who come in with abdominal pain actually don't have appendicitis, despite how common it is. Then to answer your question about kids and their ability to verbalize, this is a problem that we as clinicians need to sort of overcome and deal and work with the family. So, a child who's under 5 oftentimes they'll not be able to say, hey, the pain started in my belly button and moved to my right side, or I feel nauseous. So we often will ask them, and we'll ask the parent questions, and the parent will have to give us some information. But what also helps us is that the rates of appendicitis are really uncommon under age 5. The cases of appendicitis are really, really socked in between the ages of 8 and 15. You can get them after that, over 15 and under 8, and you can get them into adulthood. But the predominant ages are again in what I just mentioned. And so for that reason, a lot of those kids are able to verbalize.
And then how are you able to determine that it is appendicitis? Is it through an x-ray, or what part of the exam lets you know this is what the child has?
Right. So I think this it'll vary somewhat by age again, and what the differential diagnosis is. But in general, what we do is you do a good history, a good physical exam, and there's plenty of literature out there that will say that a good exam can get you to a pretty concrete idea of what's going on and narrow down your differential to 1, 2, or 3 different things. At that point, we often will get laboratory studies. We'll check a white count to see if there's signs of infection, as appendicitis isn't it, at its basis the infection is going on. We'll maybe check kidney function tests. If the child's dehydrated or not been drinking, we'll get an IV in as well, give them some IV fluids. We'll give them pain control. Once we get the white count back, if there is signs that there is an elevation in the white count, then it'll heighten in our minds that appendicitis has risen on that differential. At that point, most clinicians will opt for some diagnostic imaging. And your choices for that are either an ultrasound or a CAT scan. And depending on what hospital you're at, what time of day, you may go one way or the other between those 2 tests.
Okay. And then what is the typical recovery like for a child after having gone through an appendectomy?
So simple cases of appendicitis tend to be very quick in and out. If you came in the morning, you probably could even go home that evening because it's the procedure is relatively easy for the surgeons. That being said, I would say the advice I would give to my friends are that if usually a 24-hour hospital stay where the child recovers, and then they usually are back to their activities of daily living within 3 to 4 days, able to start eating normally in that period of time, able to start walking normally, and then usually within 1 to 2 weeks, totally able to engage back into sports at their normal level as soon as the sutures have healed and have come out. So really, your actual hospital stay, you could be home within a day if it's a non-perforated appendicitis.
And how would a parent know to be sure that the pain a child is experiencing is appendicitis? Would they want to take a child in? Would they want to call a doctor? And if so, when would you call a doctor in these cases?
Right. So the red flags for appendicitis, the number one thing I think is going to be sort of socked in right-sided pain. And the second red flag is going to be persistent pain. So, we all, as a parent, my kids have had pain, but the fact that if it persists for longer than a day, that should heighten to a family that something's going on, that I need to seek medical advice. So if your child has pain on the right side, it persists for longer than a day, you start seeing them vomit, they start developing a low-grade fever, those are absolute reasons that you need to seek care. I would always start with a phone call or a visit to your pediatrician. They can do a proper screening. They can call ahead to the emergency department to say, hey, my child is coming in with X, Y, and Z, and they can help speed the process up once they come to the emergency department. They also can tell you where the best place to go is. As we're at a pediatric facility, so we handle things differently than other facilities. So if you go to your pediatrician, oftentimes they'll recommend go to a children's hospital. You'll get care there in a certain manner, and they can recommend where in your community that is.
I've always felt like appendicitis is it's by chance or roulette, where there's no way to know that you're going to experience appendicitis. But are there things you can do to prevent it? Are there steps you can take to reduce the risks of it? I know we kind of talked about heredity, but is there anything, or is it as unpredictable as I think it is?
I think, unfortunately, it's probably as unpredictable as you believe. At this point, we don't have a genetic test of any type, and I suspect that may not occur for some time. There are researchers out there that are trying to develop blood and urine tests for appendicitis. Essentially, they're trying to measure infection in the blood or urine by specific enzymes or proteins. So there's a company out of Colorado that's trying to do this, and there's a company out of Boston that's similarly trying to look at urine proteins and as a sign of infection in the appendix, and is this indicative of an infection that needs to be addressed?
Because the appendix seems to be a leftover organ or piece, are there cases where kids are born without an appendix?
Yeah, it's a very good question. I don't know if I know the answer to that. I would say that to my knowledge, it's present in most everybody, but I suspect there may be a few people, who have evolved to a point who don't have one.
Maybe someday we'll
Right.
get there. And then how about the specific time frame between when you start to feel pain and then it could potentially burst? I know you had said that you really have 48 hours, but is there ever... does it vary per case? I mean, I can imagine there's maybe the onset of symptoms and then a burst shortly after, but I don't want to put words in your mouth or anything.
These are good things to think about. We say 48 hours, but there is a lot of variability in that, in the sense that we still don't know why some kids present perforated straight out, and what in their genetics or their infection or the type of infection that's ongoing that cause them to perforate much more acutely, because they present with this sort of diffuse pain, vomiting, they tend to have a high-grade fever, and then based on imaging, we find out they're perforated. I would say in general, though, for the vast majority of, for a good chunk of the patients, they have that 24-hour window of pain that migrates from the belly button to the right side, the nausea, the vomiting, the pain with walking, the low-grade fever. Once they get those symptoms, they're usually seen by a clinician. They're usually seen in an emergency department. We make the diagnosis, the appendix is taken out, they have an uneventful course. What happens in some cases is either the child doesn't communicate to the family that they have symptoms, and that's usually in the younger kids. Because or the family thinks this is a simple gastroenteritis. I went to my local urgent care; they didn't think it was anything significant, and I think the child is okay. Or thirdly, for whatever reason they're seen in an emergency department. Their evaluation is negative, but their pain persists, and then they go on for 48 hours of symptoms, and at that point, the appendix perforates. So in the literature, we say the mean time to perforation is 48 hours. So if you look at all kids in multiple studies, that would be the number that we would throw out there. So I would say to families, if you've been seen by a physician or not seen by a physician, if your child has had pain for greater than 2 days, you got to get seen.
You had mentioned that there are times where surgery is delayed after a bit of time. Is surgery always required when it comes to appendicitis?
So that was the current line of thinking up until, I would say, the past maybe 3 to 5 years. There's been some researchers out of the UK who have been looking at treating appendicitis with IV antibiotics. And recently there was a trial that was run out of Michigan looking at the viability of this approach in children. And I think what we're going to see over the next 5 to 10 years is that as is a bit of a new approach, that some children could get managed with IV antibiotics, whereas others will get a surgical procedure. How we differentiate that group still needs to be worked out for the safety of the approach. But as you alluded to, there is this idea that since it is an infection at its core, could we treat it with IV antibiotics and then suppress the infection? I'll tell you, though, that in both that UK study and in the study that was done out of Michigan, eventually they advocated for an appendectomy, and what we call a delayed appendectomy. The example that they give that why this case might be useful, let's say you're a professional tennis player and you have a tennis tournament coming up and you start having some abdominal pain. Well, you could theoretically go in, get IV antibiotics, get ready to play for that tournament, and then 6 months later go in for a sort of an outpatient procedure to have the appendix taken out.
I was wondering about children's efforts in reducing radiology and why CT scans may be harmful to kids and how this ties into how appendicitis is treated.
So when we talked initially about the choice of imaging, you have ultrasound or CT as the diagnostic modalities. The problem with CAT scans is the radiation they deliver. This is a theoretical risk. We don't have any hard numbers to say that there is an absolute connection between radiation delivery and cancer. A lot of this data is based on what happened in Hiroshima and observational data. But the accepted sort of party line within medicine now is that we should do as less CAT scans as possible. We should expose patients to the minimal amount of radiation that is useful or required to get a good imaging test. So along that philosophy, we've tried to look for other diagnostic tests. So that's like the blood and urine tests I talked about from these companies, as well as more an aggressive use of ultrasound. The biggest issue with ultrasound is that it's technologist dependent, meaning the technician who does the ultrasound needs to have a fair amount of learning, and they need to do this multiple times to get good at it. CAT scans are machines and they're robotic in nature, versus ultrasound obviously is by a tech. So sites that do ultrasound a lot get much better at it. And the place that you would see a lot of ultrasound done of the appendix would be at Children's Hospital. And so you see this nationally at places that do a lot of ultrasounds, have very good performance with it. They're able to show that they don't need to use CAT scans. Sites that do very little ultrasound tend to not believe its results. They tend to get a lot of equivocal results that are not interpretable, and then they end up doing CAT scans anyway. So what that comes to us of how should we manage children, and what your pediatrician will likely recommend is that if you have a children's hospital in your community, we have one obviously in Minnesota, they'll recommend you get seen there. That's where pediatric surgeons are located. That's where pediatric ER physicians are located, as well as pediatric radiologists, as well as technicians who have done this thousands of times. So they can reliably do the ultrasound of the appendix and give us a reliable result. Now, there's always going to be cases where they couldn't see the appendix, or maybe the result isn't perfect because of the body habitus or whatnot. But in general, there's been huge efforts at our hospital in particular to reduce CT scans to a very low number.
It sounds like it's a part of the evolution of medicine. And that's one thing that I marvel at each year and each decade is the steps that are taken throughout the medical community on improving. I think about recovery from knee surgery, where it was 2 decades ago to where it is now. What are some of the leaps that have been made in this area in recent years, whether it be the past year or 5 or 10 years?
I think that one of the biggest changes obviously has been IV antibiotics and post-op infections related to that. That's going to be over the past 20 to 30 years, if not longer. The second is going to be the movement away from open surgical options to laparoscopic options. If you have an open procedure done, it tends to make a longer recovery. There's higher rates of complications versus a laparoscopic procedure, which is done through small ports in the child's abdomen. The child tends to have a much quicker recovery. And the third biggest sort of change, I think, has been in our ability to diagnose this more quickly. So the use of CT scans, the use of ultrasound. And then over the past 5 to 10 years, we've started to standardize our care. As we've had this body of information of the antibiotics and the best way to do the surgery, we've started to say, how do we take these approaches and apply them to all kids so that everybody benefits? The biggest sort of problem in medicine in many ways is the variability. So what we've done in our hospital is we've tried to standardize the approach through standardized ways of delivering pain medicine, standardized way of checking labs, what antibiotics to give, and what imaging tests to even get. So that we have a standardized approach. The surgeons know exactly what to look for. The ER doctors know exactly what to look for.
What are some other questions that parents come to you with when their child is experiencing appendicitis? Are there things you hear on a frequent basis that you address?
I think parents' first concern is how do we know this is the right diagnosis? And I think for that, we have our experience that we can communicate to them, and we've seen many of these patients before. If we've done imaging, that often is very reassuring to them as well, because it's something they can understand and sometimes even see. The next thing they're worried about is their child's pain. And, the child's uncomfortable, sometimes they're vomiting, and they can have intense pain. So we address that with pain medications. We address their vomiting with IV Zofran and other medications. And then the third thing that they often will ask about is the recovery. And how long will I be in the hospital? Is the surgery safe? How often have your surgeons done this? In my position, I'm reassured by saying we have pediatric surgeons here. This is their bread and butter. They've done this thousands upon thousands of times. We have pediatric anesthesiologists here. That's all they do is take care of kids. I think that they're reassured by that information. But certainly those are valid and important questions that any family would ask.
Is there anything else before we go that you'd like parents to know when it comes to appendicitis, since it doesn't affect just a segment of the population? Everyone seems to be fair game when it comes to this.
I think the key thing to take away, and what I've learned, is for the family to be vigilant if their child has pain. 12 hours is probably a fair game for most viral infections. Once you've gotten beyond that period of time, your child's still in pain, still with right-sided pain, pain with walking, nauseous or vomiting, give a call to your pediatrician. Make sure they're in the loop. After that, if you're not comfortable, you're not satisfied with the information you've received, come to a pediatric emergency department so we can evaluate you and we can make sure that we catch this before it perforates. If we can do that, the child's going to have an excellent recovery.
I thank you for your time, Dr. Kharbanda. I appreciate this information. It's valuable and it's important, so we are grateful that you're here with us today.
All right, thank you.
Thank you.